Let's go with BPPV. Let's start BPPV. It is benign paroxysmal positional vertigo, right? Benign paroxysmal positional vertigo. Benign. What do we understand by benign? Benign is harmless, right? Paroxysmal. What happens is it comes and goes. It comes and goes. Positional, when you change your position. When you change your position, what you get is vertigo, right? You get dizziness. So this is your BPPV. Is it something to worry? Not really. How long this vertigo episode lasts? Just for a few seconds to a minute, maybe, whenever like suddenly change the position of your head. So it's a condition of the inner ear causing sudden intense vertigo, usually triggered by specific head movements. So what you get is BPPV, and it's always good to break it down properly. What is BPPV? Otherwise, patient might be thinking I might have a very big thing, BPPV, but we know it's nothing much to worry, isn't it? So what is the presenting complaint? Maybe vertigo or dizziness. So what you are supposed to do here is you have to take history in three pattern. That is your before, during, after. So patient has got vertigo. Ask whether there was any jerky movement, any loss of consciousness, whether patient is feeling sleepy, drowsy, any trauma if patient has got nausea, vomiting, all those questions you need to ask here as well. And then obviously you'll ask before as well, just to make sure you're ruling out your differentials properly. What else you have in BPPV? Usually you have got vertigo, that's there, plus nausea, vomiting. See, anytime you have got vertigo, that can give you nausea, vomiting, right? But are we going to have other things? Are we going to have fever? Answer is no. Are we gonna have hearing loss? The answer is no, right? So that is the main thing here. So what you're gonna get is nausea, vomiting only. Vertigo, nausea, vomiting. That's gonna be your BPPV. It is triggered by the specific head movements, and it's gonna last for a few seconds to a minute. That's your BPPV. What are gonna be your differentials? Your differentials gonna be again vestibular neuritis or labyrinthitis. So vestibular neuritis, I'm gonna ask definitely for fever. Hearing loss, I'm gonna ask for labyrinthitis. Mean ears, I'm going to ask again, hearing loss is there, and then tinnitus, ringing sensation in the ear, fullness in the ear, I'm going to ask. For acoustic, again, I'm going to ask for maybe vision problem. I'm going to ask for numbness on the face as well, right? So this is something I'm going to ask for acoustic, right? And what else? So diet, alcohol, smoking, all these risk factors, that is something that you can ask. And what you can do is general physical examination. Vitals we're going to do. Neurological examination, because vertigo is there, so it's better you mention neurological examination as well. And if your diagnosis or differential going towards BPPV, I want you to mention the specific thing as well. That is your Dix-Hallpike maneuver. Mention the word Dix-Hallpike. So this is going to be really important, right? So when you say Dix-Hallpike, so examiner, you might get the findings from their side as well, right? Now the treatment, it depends admission or you want to treat the patient as outpatient. It depends on the symptoms. If you feel patient has got severe nausea, vomiting, and so in that case, you may have to admit the patient as well. You may have to give IV fluids, because if patient is drinking, anything they're drinking, it is coming out. So maybe you have to admit, but less likely. Usually you can manage these patient as outpatient, right? So just telling them the management plan, so you can actually send them home as well. Most probably you don't need to admit, but if in case severe nausea, vomiting, you may have to. All right. What's the treatment? Treatment is, first of all, do the symptomatic treatment. When patient has got nausea, vomiting, you can go for antiemetics as well. And diagnosis you're doing with Dix-Hallpike maneuver. The treatment is Aplai's maneuver. So it's another kind of maneuver that you're going to do. So the patient is going to feel better, right? And what they say is 80 to 90% of the patients, they do feel better when we do Aplai's maneuver. If not, then what we have to do is we have got branded exercise as well. We have got branded exercise as well. We can do those as well, but less likely needed for BPPV because patient is going to feel better when we do a place maneuver. All right. Again, the rehabilitation lifestyle modification, that's something you're going to tell the patient to do. Keep yourself hydrated. Move your head carefully and slowly during daily activities. Sit down when you feel dizzy. So some general advices, that is something that you can give it to the patient. Another thing, do not forget to give warning signs follow up before you close the station, right? So follow up and the warning signs for Meniere's, warning signs for acoustic neuroma, so blurring of vision, double vision, weakness, hearing loss. Let us know or come back to the hospital. That's something that you need to do. All right. IPS, ICE, idea, concern, expectation, very important. Always give the information in bits and pieces and check their understanding. Patient involvement in the consultation, it is patient-centered consultation. Acknowledge their emotions. Uh, Body language, very important. Signposting, that is something that you can do. And make sure you are listening to them actively, showing them active sense of listening. All right. They might ask you some questions. Will it go away? Yes, definitely. Give them the reassurance. Yes, yes, it will go away. You don't need to worry about it, right? It's going to take maybe a few days before you feel better, but you don't need to worry about anything. Is it serious? No, it is not. It's a benign, it's a harmless condition. So these are the things that you need to mention to the patient when they have got BPPV. All right.